computerized tomography, right? So high resolution means in which we get a better detail, better imaging quality, low PV effect, and something more which create a difference in contrast and imaging modality. So what is HRCT? The HRCT represents the high resolution computerized tomography, as I have said, and also it create the visual difference when you see the internal auditory canal, the minute pathologies over there. So you can easily differentiate between the two kind of things that you are doing normal CT scan, you are doing HRCT. The difference between normal CT and HRCT is it will create less proton starvation, it will create less artifacts that will create by the posterior cranial fossa. On that case, the minute pathologies like cholesteatoma to some kind like the plate of Tura, as we discussed about the middle ear. So there is a internal at the proximal end of the internal auditory canal. There is a part in the area which is called scutum, which is mostly affected by the CSOM, chronic suppurative otitis media. So on that case, if there is a minute change or erosion, that is called the cholesteatoma, the topic of discussion of today. So we have to be very detailed in that kind of imaging. Sorry. So what are the objectives of HRCT? The HRCT has the objective to produce high quality imaging, high spatial resolution. So what is spatial resolution? As we all know, that to objectify or to differentiate between two delineated structures. That if the patient is suffering from, if a patient having come with a history with a pleural discharge or scanty discharge from his external auditory canal, it may be granulation, it may be some kind of mucosal discharges. So on that case, we have to be very precise in imaging modalities. Like if we do, we can do MRI temporal bone also, but as far as the CSOM and its indication and symptom is concerned, we have to go for bony erosion and the effective region, the effective organ of CSOM has been concerned. So on that thing, CT is more preferable and more in the case of priorities. So at that moment, we have to go for HRCT temporal. So there are the two images we have seen. That one is a normal CT scan thicker slices, and the lower one is HRCT temporal with thinner slices. In these two images, you can find the ice cream cone shape appearance. The ice cream cone shape appearance of the malleus and incus. The head of the malleus and the incus are better visualized in the HRCT than that of the normal CT scan. So these are the terms that we have come across in our topic HRCT, that means high resolution. What high resolution defines to us. So now after going deep dive in CSM, we have to know, now we can know that what HRCT means to us. So let's discuss about it. So anything after going any procedures, we have to make clear a concept about the parameters, that on which FOV we have to set, on which KV, or what should be the KV, what should be the MAS, and what should be the limitation of a patient. As because we are a radiation worker, we are medical technologist, so we have to be very careful regarding that. I have to be careful regarding a patient who is at its adult period, or like the patient who is having like at the age of 20 or 21. So on that case, we have to be very careful regarding using the radiation dose to a patient. So the FOV, the parameters, the KV, the MS is very much important in that case. But as we know, HRCT is a type of CT scan in which we use low pitch value, so that more the overlap has been done to that same part. It creates a high resolution image. As the pitch is concerned, that pitch comes with a definition of inclination of the gantry with that of the thickness of the collimative X-ray beam. So the less the pitch will cause increase in the scan time, but it will get a better output as HR resolution, high resolution. So these are the scan parameters. Head first supine, as we all know, as we have everybody, maximum of them are working in a CT scan or is going to work in a CT scan. So as a temporal bone is concerned, temporal bone is a part of the bilateral symmetrical organ in a calvaria. So we have to put the patient in the headrest with head first supine position and FOV of 9 to 10 with a slice thickness of 0.63. So there is something, the question is there, why is 0.63 or why the minimum slice thickness is there? So as we all know the artifacts of CT scan, that CT scan has a very, it has its habits, like if we have two voxels are there, if one voxel has the high density part and another voxel has a partial part of that high density organ, it will create a same homogeneous effect to that image. So on that case, if you take the thin slices, if you take 0.63 slices, 0.82 slices, so we have decreases the effect to that part of imaging acquisition. So that's why that's thin slices, and as because CSOM is concerned, the erosion, the rate of erosion and the change in every slices to hypotymphanum to hypotymphanum, then mesotymphanum, then epitymphanum. There are multiple parts that we have to look for. So erosion on that case will create changes for previous further diagnosis. So positioning as well as that first supine is the positioning. Now acquisition pathway in which we have to set the parameter and the image acquisition, that we get the images, like we have get the raw data or we have get the Excel cards, then we should reformat it for our own purposes. This is the normal study of a normal patient having a HRCT temporal bone. This is the mastoid cell sinuses, the external auditory canal, the internal auditory canal, the Malleus iceman cone shape appearance, and the external tympanic tegmentum. So this is the normal case of a normal temporal bone with contrast, which will going to interact with the CSOM. Now, what do you mean CSOM? CSOM is a disease which is a secondary effect from a long-standing LRTI, URTI, upper respiratory tract infection. So CSOM has multiple sources of origin. That is, it may cause from blood bone, or it may cause from long-standing RTI. Long-standing upper respiratory tract infection, and also it may generate if many of the people has come with a history of a pain in effluent discharge from last previous months, and now it increases with a scanty discharge with foul smelling. That means the CSOM is converted from chronic suppurative otitis media to anti-contractile suppurative otitis media, that is unsafe, in which the discharge is more emulsive with a bloody stent also. That means, as we know, that CSOM has come with a symptom of erosion of the tympanic membrane, perforation of tegmentum tympani, and cochlear comodity that leads to autophoning and many other effects. So this would be the stage on which we have to be evaluated for otoscopy and other further examination to make the patient very stable, so that he will be able to regain its initial hearing skills. So cholesteatoma. Why cholesteatoma is mainly because cholesteatoma is a aggressive bony erosion of internal auditory structures. Because in case of CSOM, the thing is that when the infectious disease, basically Streptococcus, Staphylococcus, are those major bacterial infection that leads to CSOM, and which has a greenish and bluish discharge from the external air. It may be misinterpreted with CSF Ottawa. CSF Ottawa has the same kind of discharge with a whitey bluish smell. But we can easily evaluate the difference between CSF Ottawa and CSOM by its smell, which is a rotten smell of fish. That's why it has been very easily differentiated that CSOM, as the patient comes with a history of external fluid discharge, the greenish color discharge along with the brownish of air wax. So we can easily differentiate it on that thing. So cholesteatoma is an aggressive keratinized cell formation in the internal auditory canal due to multiple granulations of cell. As our body is always trying to resist, our body tells ki, if the patient is suffering from fever, our body tries to be immune and increase our body temperature to fight against those pathogen or those. So that kind of thing, when our internal auditory canal is suffering from an infectious disease, our internal auditory, our mucous cell, goblet cells are there which try to resist and gives through proliferation of the cells. So on that margin, if proliferation is in a case, it will cause edematous appearance on the internal organs, such as the focusing organs, which the focusing part of internal auditory canal is the crura, the tegmentum tympani, the Prozac space, the internal auditory canal, majorly the three main parts, that is epitymphanum, mesotympanum, adatus to and hypotympanum. These are the major affected regions that we have to look for. There are the two main causes of CSOM, that is as the socio-economic status of, if we say in our economic, as we are living in a super city like Calcutta. So there are two parts of Calcutta in which people, those who maintain the hygiene and those people are still using matchsticks to put down their hair. So in that thing, matchstick is also not an earbud that will clear your ear. It will be more harmful, that will create infection to the inner ear. So on that aspect, congenital and acquired has been classified on the basis of socioeconomic status, and there are some disease like in some conductive hearing loss that's done by the congenital patient come with a early state of in the early state of a child come with a hearing loss. This may be cause of some congenital anomaly. So it is in that case we have a different kind of evaluation status. So we have to go for track DTI imaging in case of AMR. So finding the CSM, that what CSM stands for. So first one is we have the mucosal granulation tissues over internal area ossicles. If you are currently located that the ischian part or the ischian part of the external auditory canal forms a mass and forms a follicular mass over the plate of Tura and the cochlear promontory region. So this is not a tumor, or this is not a So that part is the follicular part that is developed over there. It is the granular tissues that will resist the more infection to the basically the mastoid cells over there. So the next is erosion of cochlear promontory. So a patient with a post-operative case of having a granular meningitis or something, having a case of tumor in the sphenoid sinus has come with a patient and doing an HRCT temporal bone, that the patient is having OT in the left side and now he is developing a false discharge in the right side. There are many cases. So on that case we have to get that the patient is having a granular meningitis, which is also a complication for external auditory canal infection. It may generate due to hygiene properties over there. Now the third one we have to look for is the keratinize of our mastoid ASL sinuses. That mastoid ASL sinus which are over there has, you can see proper. Sorry. You can see that those mastoid ASLs are there having totally keratinized, and also there is a sclerotic lesions over there in the squamous part or antimanic part. There is sclerotic lesions which cause an effect of cholesteatoma, and it will give a proper justification that the patient is having if those three symptoms are there in a patient. Not this one. If the patient is having a mucosal granulation in the internal auditory canal, if the patient is having cholesteatoma in the external wall erosions, then we can say that this is a clear case of CSL. Now this is there is a patient having an age of 21, which came with a history of she came with a history of pleural discharge, scanty, foul smelling, and recurrent removal of internal ear skins. You kindly get that there is a mucosal thickening, the mastoid ASL sinus is totally occluded, the trabecula has not been visualized properly, the jugular bulb has also got a dilation of a bone. This part, the tegmentum tympani, the ASL is in the H shape. The H shape is very much important over there. As we visualize, the H shape is there. The H shape is called, this is the part of the intermediate layer. We can the superior part of the 8 is the epitymphanum, the 8 is the diatocytantrum, and the inferior is the hypotymphanum. So on that part we have to look for the CSL. Now this is another case, patient comes with a trauma of tegmentum tympani with a bloody discharge. Sorry. So these patients come with a history of trauma in the left ear, and also having a history of ear sensation of hearing loss. The part is totally occluded, and this part of the external auditory canal is completely diminished. So on that case we can say this patient is suffering from traumatic injury, and also later on developed to an acute CSOM. So this is all about my presentation. Thank you for the team of ISRT for giving me this opportunity.